I just started my own business. Where can I go to find qualified applicants for my staff?
I have questions about new procedures in the industry. Who can I ask?
Where can I sell my old equipment so I can buy new equipment?
I just graduated from school. Where or how can I find a job?
You may have questions about the beauty industry, but don't know where to find the answers. That's where Salon Channel can help. Whether you're choosing career opportunities, searching for a school to learn and be certified, looking for professional equipment and products to build your practice, networking on our message board to build relationships with other professionals, finding someone qualified to join your staff, selling items on our auction, or just simply discovering yourself. You will find your answers on Salon Channel's easy-to-use site. Every business needs information and contacts to stay competitive and profitable. That's what Salon Channel offers. You are an expert, a friend, and an inspiration. Know your industry. Know your clients. Know who you are. Salon Channel, where beauty meets technology. This video is brought to you by Aesthetic Video Source, the leader in quality educational programs for professionals in the spa and beauty industry. Among our award-winning videos, you will find instruction in every aspect of the business.
Push, rip, and apply pressure.
You will learn from seasoned professionals who currently work in the industry.
So now I'll do the second cleanse with the steam going on my client.
Not only are they experts in their particular area, but they also know how to effectively teach others. As a professional, your education is ongoing. Our video training is a great way to learn new treatments and services, or to enhance your knowledge of services you already provide. These programs will improve and expand your knowledge of services, help streamline your business, and ensure the most pleasant experience for your clients. For a complete list of our training videos, visit our website where you can order online, request a catalog, and share ideas with other professionals on our message boards. Thank you for choosing Aesthetic Video Source as your training provider. Enjoy the program.
Hi, my name is Mead Stedman, Aesthetic Video Source, and I would like to welcome you to this video on deep tissue massage. I'm a licensed massage therapist and have been since 1995, and I've been an instructor for the Myotherapy College of Utah and the Myotherapy Institute of Massage for over 10 years. Now, deep tissue massage. What is deep tissue massage? It's a lot more intricate type of work, very detailed type of work. Swedish is very relaxing, a lot of times very flowing. Deep tissue work is very specific. Very specific work. We quite often have musculature that is tightened, which inhibits range of motion, which inhibits the ability of the body to balance and carry itself the way it should. Quite often joints are impinged or held together by this hypertonic musculature. When we are doing deep tissue work, this also can involve pain, pain tolerance levels, and there's a big difference between something that's very manageable and something that's very intolerable. In order to have these, we need to set up a parameter of, I usually use, and it's very common throughout the industry, a scale of 1 to 10, 1 being nothing, it's very comfortable, I don't feel any pain. 10 being extreme, I can't handle it, it is very intolerable. Now, on that pain scale, I ask the client to make sure that it's according to them, what they feel. And I like to keep them, if I push the envelope, up to about a 7. If you get to an 8, I always have my clients say, ooh, that's approaching an 8. And it's very important that if they do tell you it is approaching an 8, that you back off a little bit. This nurtures and enhances the trust that you need to have between you and your client. If they don't trust you, they're not going to relax, they're not going to release, and they're going to keep defending. And of course, defense responses recruit the musculature quite often that you are trying to release. So, very important aspect of this type of work. Now, here's some benefits to deep tissue massage. Quite often, deep tissue massage is needed because there is some sort of an imbalance in the area, whether it's torso being hyperextended, being hyperflexed, having that so-called yin posture, or just having carpal tunnel issues or signs of carpal tunnel, joints not moving very well. Deep tissue work will address a lot of these impinging situations or restrictive situations and allow for a lot more freedom of movement, flexibility. And this can be very important in just everyday life as far as maintaining balance for someone. I do want to say this though. There are some things that no matter how much you address, they won't get better. Allow your client to have their distortion. Some massage therapists get in the idea that they're going to fix everyone and fix everything. Remember, there are certain dynamics and certain aspects that make up the person. You want to improve as much as you can, but you don't have to fix everybody. We all carry around our burdens in life and different things that we have going on. Whatever we'll release, and it's okay to leave them walking out the door with still some distortion or something happening. A lot of times what we're looking at is maintenance of a situation, trying to help the situation so it doesn't keep getting worse. So very important aspect when you're working on somebody. Another benefit of deep tissue massage is just releasing restrictions or adhesions from either an injury or scar tissue around surgeries. When you get these restrictions going in place, by getting in there and mechanically working on these, you can open up either an area of the musculature that has been restricted or decreased in length by some of these adhesions, by some of these restrictions. It can be very intense work, but it can open up and allow for a more normal range of motion. Also, just musculature that is hypertonic, a lot of primary and secondary distortion. And quite often with primary and secondary distortion, massage therapists have a tendency to work in the area of complaint pain-wise, and they neglect to look to the opposite side, which quite often is the source of the primary distortion, and there are no symptoms of pain or discomfort initially. So be aware of looking around and assessing the entire area. Now, here are some contraindications that you should be aware of when doing deep tissue work. First of all, any type of deep tissue work increases circulation. When you're increasing circulation, you also can get an increase in toxins, the metabolic waste products that can become trapped in tissue when the tissue and the blood supply is impinged. With that flow, if you have a compromised immune system, your body is going to have an adverse reaction to that, and your client may not respond as well as they could. If they're having chemotherapy, radiation therapy, if they have a contagious disease, you may make that condition worse due to the fact that metabolic waste product release or toxin release has a very dramatic impact on the body's immunity. Injury. Injury is another important thing. If your client has had surgery recently or injury, I like to look at injury in the aspect of, typically with surgery or injury, I like to wait 6 to 8 weeks after the initial acute stage of what's taken place. Now, there are different degrees of injury, but I want to make sure that I'm not going to harm my client at all, that we've had quite a bit of time for the body to heal from that initial assault. Blood issues. Blood issues could range for your client has a propensity to bruise easily, whether it's from weak vessels or other things. If they're taking aspirin, Coumadin, blood thinners, bleeding could also address things like aneurysms, a bulge in the arterial wall. An aneurysm, if it's not directly associated with the area that you're working, you want to approach that with caution. That's if they know they have an aneurysm. You can do deep tissue work if the aneurysm is away from the site of where you're working, but you want to be very cautious because you can still impact arterial blood flow, which could impact that aneurysm, or just increasing blood pressure, which has or can have a dramatic effect on the aneurysm. But overall, any bleeding issues, if you're doing deep tissue work, that may be contraindicated. Pregnancy. Here's something that's very important. Women during pregnancy have a hormone release of relaxin, and what relaxin does is all the ligaments and tendons in the body have a tendency to relax. They elongate, and that's so that pubis symphysis can open up and we can have a normal vaginal delivery. And if relaxin is through the body, what you could do is damage a joint. You could cause it to be hypermobile by doing a lot of aggressive work. So in pregnancy, a lot of times it doesn't have to do with the fact that the woman is pregnant. A lot of women go out and run and exercise and work out through most of their maternity time. However, it's the relaxin that you want to remember, the impacts on the joints and the soft tissue. So this is a short list of contraindications. Make sure that you understand contraindications associated with doing body work. Go over them with your client and make sure that it's safe to work on them. In this particular demonstration, we're going to be focusing on extremities. And by extremities, I mean the arm from about the shoulder girdle down, biceps, triceps, flexors and extensors of the wrist, also pronators and supinators, and the leg from about the pelvic girdle down, the extensors and flexors of the knee, the plantar and dorsiflexors of the foot, and the inverters and everters of the foot. So let's get started. Now here's the procedure for working on the arm, for working on the upper extremities. Of course, when I do anything, I like to warm it up. Again, since you're working your way into the tissue, you need to ease your way in. And so I will start off with some effleurage strokes. And as I effleurage, I palpate for hypertonic regions. I try to feel for how the arm moves as I'm effleuraging. And another thing that's really important, and I'll say this time and time again, is your body movement, your body mechanics. As I'm doing that effleurage stroke, you can see that I'm kind of gliding, and that's legs. I'm gliding with my legs. I'm trying to stay upright. I don't want to get in like this. I want to be relaxed and not compromised as I work, because that will continue to enable me to work for a longer period of time. Now I'm going to get in with a little more, this could be considered an effleurage / friction movement. And I got one of my first signs as I was going in there, kind of tightened up her arm. And that's a sign that a lot of times you're working a little too deep. Is that the case? Is that working just a little? No, okay, not too bad. All right. And now I'm going to isolate in to the flexor side of her arm. And especially when doing deep tissue work, you want to make sure that you don't use too much lotion. I just want to get a good glide in there. I don't want to slide, especially if I'm using a lot of pressure. But I'm increasing my pressure a little more, still an effleurage stroke, almost getting into a little bit of kneading, some petrissage. And while my thumbs are working on the anterior side, I have my fingers working on the back side. This is just a warm-up still on the extensor side. Now, I want to compress into the flexors. And typically I'll use the heel of my hand when I'm compressing down. I'll just gently go in, and you can see as I compress those flexors, her fingers will actually flex. And when you get near the radius and the ulnar sides, that's where you get more of the carpi flexors. In the center, you will get some carpi and palmaris, but also more in the center is where you'll get a lot of the digitorum flexors. Again, that compression is going to reset proprioception and allow the tissue to release. You can also do this on the table. And even isolate more specifically, getting into the individual flexor muscles, you can use your thumbs. I'm going to get into the palmar region, and I want to kind of glide and open up the carpals. The carpal region. It's almost like opening up a head of lettuce. Just get my fingers in there and just open up the carpals. And I may go back and forth with the pads of my fingers, and I'm pushing against the thenar eminence of my thumbs, and it's almost a petrissage type of movement. And I can feel the attachments in the carpals. Now, I'm going to start with I'm going to strip down from each finger through the palm, and I'm going to work a little retrograde. I'm going to compress in for the little finger, and as I compress in, this is what I talked about before. This is that compression to insertion that I was talking about. I can feel as I compress in here the small, more intrinsic flexor, palmaris, offer a little bit of resistance, and I'll just compress against that and hold it until it releases. And as I hold that, you can see my thumb slowly moving, and that's just following the release of the muscle. I'll move up a little higher, and I'll do this along all of the metacarpals. Another way you can do this is simply put your knee up on the table, and you can compress into your knee. How's that pressure? Good, okay. And as I said, this compression towards insertion really helps strip out the muscle too. And so I save a little bit of time. And I'll move over to the middle. Now we're going to start getting into some of the flexor adductors of the pollicis. I'll address those individually. This just really helps open up the fingers. And again, body mechanic wise, positioning wise, I may be pushing with my thumb, but I'm actually leaning into it with my whole body. And if you can see the direction of my thumb as I compress, I have my joints aligned all the way up my wrist into my arm. I'm not coming in an odd direction this way. If you compress and follow the joints of your thumb, since typically in massage therapy, therapists have a tendency to really use their thumb for a lot of the deep work, this will help you with the pressure and sustain the pressure, maintain the pressure, and have your thumb hold out a lot longer. If you wanted to, and you would have to be really careful with it, there are a few options. I like to use my pisiform as an optional thumb and actually glide in there this way. And if you can see, I'm supporting her hand in my other hand and just gliding down with that pisiform. Similar type of action, and it requires getting the palpation skills for using that pisiform. Another option would be olecranon process. Just feel that olecranon settle in. Right now I'm on the middle, the third digit. And I'm just doing the same type of thing. I'm feeling that tissue release and gliding down with it. Now be aware that when you're using the olecranon, I can get a lot of power and force in here that could cause a lot of pain. You have to make sure you feel and establish that communication with your client. There are a couple different options. Now as far as getting into the pollicis, what I like to do, I like to get that flexor pollicis longus and brevis. Here's more of that compression directed towards insertion. I'm actually going to compress into the saddle joint with the thumb. So I'm directing my pressure down to the insertion of the flexor and also compressing that joint, being very careful. And I'm going to feel that barrier and follow it down. At the same time, I'm going to come into the flexor pollicis longus, and I'm going to glide up with my thumb towards the carpals. And what will end up is, as these two release, I'll get a nice release with the entire thumb. Now you don't have to do this simultaneously. I just do this simultaneously. You can just do one at a time if you want, but you can see my thumb, my left thumb gliding down. Now there's a little bit of a barrier. You can even see the belly of the muscle in her palm kind of push out there. And there goes with the thumb of my right hand gliding. Also, getting towards the wrist. If you feel a pulse or anything like that, back off. You're probably on an artery. I'm going to glide this with my left thumb all the way down till I feel the carpals, and it just kind of slides out underneath. There we go. So that's really getting into the palms, the palmaris, the insertions, the attachments, and getting things to let go. You can also strip out the fingers if you want, depending on what's happening. You can get ligaments to release. You know, some people get little ligamentous strains in their fingers. If there's not an acute phase of things, by just stripping these areas out, you can help return that balance. A lot of massage therapists, this is awesome work for because we're so intense with our hands. Now that I've opened up that region, another thing you can do as far as for the polysis, by the way, for some pregnancy, this would be contraindicated, just this holding point. But I'll just grab and compress this point until everything softens up. Now I can either pinch it with my thumb and index finger, or I could place her hand here and just compress back through, or I could put her hand on the table, compress through, however you want to use the surface. But the main idea is just to compress this region and be very careful, because this can be a very, very, very tender point, especially the interosseous border between the first and second digits. And as that tissue releases, I just follow it. Hopefully you're starting to see a pattern. Now I'll flush, 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 however you want to flush. Here's another way to flush. Now I'm going to work with the flexors. Okay, I'm working with this thumb and really decompressing where all the musculature is for the thumb. I'm just trying to help decompress that. And before I move on to the rest of her arm, to the flexors and the extensors, she damaged her thumb in a biking accident. And go ahead and wiggle your thumb. She has very limited range of motion. And so there's a lot of scar tissue through here. We're not pinned here anymore. But what I'm going to do is very carefully, because this is for her, this is a really highly sensitive, painful area. I'm going to do that instead of compress towards the insertion, I'm going to compress above and below this distal interphalangeal joint and compress it together, both on the medial and lateral side, and then on the anterior dorsal side. And I've got to do this very slowly. First thing I need to do is, how's that pressure there? Good, okay. So we've established good pressure, and now I'm going to gently, I'm probably using half a pound of pressure for this particular movement. I'm moving my fingers close together. And I've found the barrier of the tissue where it just kind of holds up against my fingers. It provides resistance. So I'm just maintaining my pressure. And as things release, I'm just going to follow it. And what's happening is, in the tissue itself, I'm feeling like little cracks and shifts. And can you feel any of that? Okay. Feeling little cracks, little shifts. How's the pain? Any pain? Okay. So we'll just keep working with this. And my two thumbs have come together. Now my two fingers have come together. Now I want to come in. I want to support her thumb. I'm going to come in on the anterior dorsal side. I'm right on those flexors and extensors, the little lumbricals, and I'm compressing into the tissue. And right here I'm feeling a little hypertonic region. Is that painful when I push in there? Okay, not painful. That's good. See, establishing pain tolerance. Now, as I compress in there for about 10 to 15 seconds, I'll feel a little bit of a softening, and now I'm going to compress my fingers together. If I used any more pressure, I know it would cause pain. A way to establish that is just ask. Okay, now we're gliding together. What's happening is on the flexor side of her thumb, on either side of that joint, I'm feeling a lot of resistance. I'm not feeling a whole lot on the extensor side as my thumbs have come together, but my fingers clearly aren't together, and I'm feeling a little bit of resistance, so I'm just going to keep that pressure up, and it's just going to come together slowly. I could do cross fiber friction, I could do longitudinal fiber friction to open that up, but I prefer just to let the tissue ease up on its own. I've just noticed that when I allow the tissue to release on its own, a lot of times we get a much better release. And Pret has also told me that if it's a pretty protected area, and if I use too much pressure, she'll probably go into orbit. So that's all I'm going to do. Just now flush the area out. Flush the area out, and how's that feel? And go ahead and move your thumb. Okay. How does it feel when you move it? It hurts a little bit. Okay. So that's some of that little, we've worked an area that's been injured. What would be good after working on this is have your client ice it for a little bit to take down any swelling that's taken place. And you may get some more healing in there. But there are some specific things you can do for an injury or a past injury site where you have restricted range of motion. Now I'm just going to move my way into the forearm, and I'm going to work with kind of where the flexor tendons go up through the carpals, the flexor retinaculum, that carpal tunnel. I'm not using a lot of compressing pressure in. I'm just drawing pressure down. I'm maybe using a half a pound. You've also got to remember that with the carpal tunnel, you have the nerve through the carpal canal. Okay, now I'm going to go down, and this can be a very sensitive area for your client. I'm going to friction that medial condyle, which is a major attachment for all the flexors of the fingers. And here's just an idea. When I palpate in there, I can really feel tight structures. Now, be careful of the ulnar nerve, the ulnar notch. But usually when you feel those hypertonic regions are usually pretty tender. And how's the pressure as I go in there? You can feel that. So if I were to use a lot of pressure, you'd probably come off the table. I want to maintain that level of trust and level of safety. Okay. Now I found that when I friction insertions, that when I start to work on the belly of the muscle, it releases a lot quicker. So I'm going to start from the flexor ulnaris, and I've established the boundary. We'll give this a test. That feels like, and it's okay if I'm wrong, but that feels like what would amount to about a 5 to a 6. What does that feel? Where are we?
3.
3. Okay, good. So that means what felt like a 5 to a 6, I can apply a little more pressure. And let me know when we get to a 7. Right there. And what's interesting is I was increasing my pressure, the muscle was still releasing, so I was following it as it released. It just jumped up, didn't it? Mm-hmm. Yeah, okay. I moved to a different portion of the muscle, almost at the insertion, and you will find really common muscles to be very tender at the insertion points. especially where you have a larger insertion. There, we can see the little, how was that? Okay, kind of stimulating. And I'm flushing the region. I'm feeling still a lot of tightness down here, so before I continue to strip out and use that insertion-related compression, I'm going to get down and use a little bit more compression right on the insertion itself. And I feel that tightness either through pain threshold. Where are we?
It's lowering.
It's lowering, okay. From a what to a what?
It's now 2.
Now a 2, okay, good. Let me know when I get to about a 6.
It's a 6.
That's a 6, okay. Hardly put any pressure in there, but I just moved a little bit. And we found another painful spot. Again, I choose to use compression. You can gently friction that area if you want. Is it starting to decrease at all? Okay.
It's a 1.
It's a 1, okay. And I kind of felt that soften up under my thumb as it decreased. So now, there's just one more area right through there. And that's going to be right on the lateral portion of the flexors, both carpi and, okay. I'm just going to roll in. There we go. And where are we right now?
7.
7, okay. So I want to keep it at that 7 and just hang in until it releases. I just increased my pressure inadvertently and I got her attention. It's those things that works against that trust that we're trying to establish. Okay, now I'll come in and really strip up that flexor carpi ulnaris. Now, since I've really worked on the attachments, you should be able to get a really good glide when working down the belly of the muscles. It should almost feel, yeah, I notice that you're getting my attention, but it's kind of feeling good. Is that how it feels? Okay. So I'm just going to gently strip down the different lines of the flexors. Again, knowing where the flexors are, those individual muscles, that will help you isolate and be very specific. Now, if your thumbs are starting to get tired, that pisiform again. Brace. So I've got it braced here. I can use that pisiform and work down those muscles. If I want to be more delicate, it would be a little more broad. I could use my forearm, but you want to be careful with that. Or I could use my olecranon. How are we doing? Okay. All right. Now I'm going to go for the radial flexor region. But this is a procedure you use again and again and again until you have really gone through all of the flexor muscles. It's the same procedure where you could get into the, after you've gone through the radial flexors, you could get into the brachioradialis, which is a real hot spot on everybody. Plus you have a major portion of the extensors that all pile up on the lateral condyle. So I'll get into the carpals, kind of friction that area. Warm it up. Get into the attachments. You could use your thumbs. You could use the heel of your hand. Really warm up that area. And isolate out some of the tight regions. This will also get into the supinator muscle, the large supinator that lies underneath the brachioradialis. You have to have a lot of patience. And there we go. Doing okay. Again, we're approaching the attachment, where we sometimes see a lot of the pain. Now, if I get a lot, I'll just spend a little more time compressing through there and gently longitudinal fiber frictioning. How are we doing? That pressure okay?
Yes.
All right. Now, since we're going to be working the whole arm, you can also, on that radius, work in with a bicipital attachment. As you can see, I'm using a little range of motion with the radius to enhance my work in that region. And I've also been informed that Perrette bruises easily, so I really want to be careful of my pressure. I don't want to leave her with bruises all up and down her arm. And it's more just kind of a weaker vessel issue, she said. So I don't want to get too violent or quick with my movement. I want to be very consistent as I move through this. And we just jumped again. Good sign. Watch for things like that. Back your pressure off. We have a really major hypertonic point right at the extensor brachioradialis point here on the lateral condyle of the humerus. What I'm going to do is simply, kind of like what I did with the thumb, I'm just going to grasp that attachment, and I want to take it up to about a 6. Where are we?
5.
About a 5, okay. Tell me when we get a 6. Okay, we get a 6. Beware also that when you're working with ropey muscles like this, sometimes the ropey muscles have a tendency to twist on themselves. So as you're compressing and working with them, they can roll or flip. And if you're not properly braced, you can cause some pain when they do release and when they do unwind. Now, to me, it feels like things are lengthening and softening, and a good sign of that is the pain level starts to decrease. Is the pain decreasing? 4. Okay, that's a good sign. All right, now I really feel it letting go right along that humerus condyle. Oh, there's another spot. Again, just hypertonic tissue. It feels like the muscle softening, softening, softening. I'm just going to roll her around a little bit right there, kind of getting into brachialis. And where are we here, pain level?
3.
3, okay, so I'm going to compress. 5. It went very quickly, and I'm just going to hang out. And immediately when I say that, I feel a softening in the tissue. Is it decreasing again? Okay, so as the tissue softens, it decreases. And really, another thing that I'm doing is I'm monitoring. Since I have a hold of her hand, if you ever, when doing massage, if you watch your clients, quite often they'll grasp their thumbs, they'll flex their thumbs and fingers during the massage for different things. It's really almost a subconscious effect. And there she goes with her thumb. I'm feeling a little discomfort, and so I can respond to that from that monitoring station. You can do that either visually or just by holding on. And we have this one little point right there. Scale of 1 to 10.
2.
2, okay. And this is
5.
5. It increased dramatically. So this is right on the brachialis muscle. I'm just going to pronate her arm in. Very tight. She's a bike racer, so she's on those forearms a lot. You can imagine how the brachialis, there we go, just released. Did it just decrease? Okay, that brachialis has a lot of bracing factors, and my thumb glides as I follow that release. Okay, and after I finish flushing everything, I will go ahead and I've pretty much finished with the lower arm, and I'm going to go up and work the upper arm, and really muscles that affect the elbow. And I initially went in and flushed the region, and I still want to do just a little more warming up. And I like to go from this position. This for me works really well because if I want to, I can work both the bicep and the tricep and the brachialis at the same time. But you do what's comfortable with you. Also, getting your person in this position, if there are rotator cuff restrictions or any shoulder girdle restrictions, you may not get this much circumduction of the arm. I know circumduction is more of a movement, but if the arm elevates above easily like this, this is a great position to work from. Now, another thing is positioning again. I'm moving back and forth, but it's kind of like dancing. My knee is on the table. I have an anchor point here. I can work my body from this position. This rocking back and forth allows me to apply pressure efficiently into the arm. And plus, I've got my bolster there with my knee. Okay, now I'm going to get in here and start warming up the tricep. And I'm really stabilizing with my other hand and just kind of gliding. Remember, we have three parts. We have the medial and lateral aspect of the tricep and the mid tricep muscle that goes up into the infraglenoid tubercle. And I'm going to friction and compress right at the olecranon. And then I'll glide up to the superior shaft, the humerus, and work with the attachments. I'm going to compress the medial tricep, and as that releases, I'm just going to follow it down. Be careful of the brachial plexus, which is just medial to my left thumb. I've worked with the medial head. And by the way, just know that as you approach the axilla, quite often this is an area where people can be ticklish, hypersensitive, typically where there are more superficial arteries or nerve plexus, people are more sensitive. Be aware that it may not be actual muscle pain, but your approach to the axilla that is causing your client to withdraw. And sometimes it might be the fact that you are using your thumb and that's invasive, and you may want to switch to a heel of the hand. Now, as you can see, this is pretty twisted kind of distortion. My dad would call it acrobatics. You want to be careful if you do have your hand like this and watch your pressure and make sure everything's relaxed, because it's pressures like this for some people that really does a lot of damage to their wrist, that causes a lot of infiltration of incorrect usage of your body parts when working on someone. I've always been able to do something like this. I've never had any pain from it, and so I'll use this position. If you find pain when you're doing something, adjust your position. Just for another gee whiz, I could use my forearm again. I could use my elbow. Just moving. Just moving gently into that mid tricep. Scale of 1 to 10, where are we?
4.
4, okay. But I can go just a little above that. And as you can see, I am gliding down as that muscle releases. What's interesting, since I'm supporting the bicep, I can actually feel the bicep releasing as I'm working the tricep. It could be that just reflexive response if you want. Now, getting into the bicep, I already frictioned down on the radial attachment, and I'm going to get more into, I can work it from this side, which is what I typically do, but you can also come back down and work on this surface where you're using your thumb, and that's pretty tender. Sometimes as you're releasing a muscle, if you do the range of motion that the muscle does, with that passive range of motion, a lot of times the muscle will release. Some people will call it a pumping action. So when I put in techniques, just going through that range of motion. Now, right here, she stiffened up again, and this is that separation between the long and the short head of the bicep. Did the pain threshold increase a little bit?
Yes.
Okay. So I'm just going to hang out there and stop. Probably do some more range of motion in there. And as you can see, I don't know if you noticed a flinch, but as we got towards full extension of the elbow, there was a little bit of a flinch. Now, I am gliding more to the long head of the bicep. Short head would be moving off in this direction towards the coracoid, and the long head would be going up through the bicipital groove to the supraglenoid tubercle. And I'm now I'm starting to feel the deltoid, that anterior deltoid, and I can feel how that head of the bicep slips up underneath there. But we're releasing. I'm going to go back to that junction. There's the short head. And that's nowhere near the sensitivity as the long head, is it? No. Okay. Now I'll just flush that region. And we could, from this position, again, if I wanted to, get into the brachialis muscle. And I'm going to do similar range of motion. And typically this could take you right up to the delta tuberosity. This is also a great way to get through the brachialis muscle. If I just brace in here, come across the body a little bit, and I can draw down either this way or with the heel of my hand, and I just brace. How we doing? Okay. So, pretty much, That's how I work out the extremities. After all said and done, I'll just flush the entire area. And I would do the same thing to her left arm. Take it slowly, address the hypertonic regions, the regions of pain. Work your way in, allow the tissue to release, then flush after you're done. Be careful of the structures like the arteries, the nerves, and you will have a lot more successful session than if you just go in with wild abandon. Now here's an option to work the arms while your client is prone, get the extremities. Actually, I find it often even easier to work the flexors because they're right there for you. But the idea would be the same. You can warm up the area, and just for all intents and purposes, you can see how easy it is to get into the palmar surface of the hand, just pushing right into the table. A perfect scenario to use your thumbs, to use knuckles, palm of your hand, elbow if you need to. Working into the wrist, similar type of idea. Working the flexors. You can see as I hit the flexors, you can watch the fingers correspond to the different flexors I work. And the palmar flexors. You can get very detailed in the flexor carpi ulnaris, radius, and also the flexor digitorums, the different flexors for the digits. So there's one option here, extensors. All you do is move the hand over, and the hand can be just off the table a bit. You can get the wrist. You can really work into the extensors. Brachioradialis. All this area is right at your disposal, and just a little positioning, you can really get in there. Tricep, if you want to really solo out and isolate the tricep, you can really get that tricep attachment. Position in for deep tricep work. Brachialis. And the bicep. Depending on how mobile the shoulder joint is, you can get into the bicep just under here. Here's the biceps, brachii. You can work the bicep, get the bicipital attachments, and actually this puts a little stretch in the bicep using gravity. So here's just another option to working the extremities, the arm, in the prone position. Okay, so when we're working with the leg, with the extremities, upper and lower leg, we always begin by warming up the tissue. And just some good effleurage. Now, with the larger muscles of the body, as far as warming up goes, I like to use a little bit of friction, and it can either be the superficial friction, or sometimes I use the palmar friction. And one thing, she has a very hypertonic vastus lateralis, and when I work in there, if I'm using the hypertonic friction, I have to make sure that I don't use a lot of pressure, because that could elicit a very large defense response. But just the superficial friction allows the fascia to separate and allows blood flow to get into the area. And here I'm just using the thenar eminence of my thumb. It's almost like waving, just kind of giving a little twist. And she has a little bruise right here. That's contraindication. I want to be careful of that, especially since I'm going to be working in tibialis anterior. I need to work around that and not put a lot of pressure in the center of it. So when you are working on people, watch for these things. Now, I am going to start by working into the tibialis anterior and just getting in and doing a bit of longitudinal friction around the retinaculum, right around the musculotendinous junction, and get up in and work the osseous borders along the tibia. Now, one thing, as I'm working tibialis anterior, it is part of the anterior compartment, and you have to be really careful with the anterior compartment. I mentioned we have a bruise on here. If there's damage to the anterior compartment of the lower leg, one of the dangers that you have is if you get any swelling in the anterior compartment, it can actually inhibit blood flow to the lower leg, and even more so inhibit the venous blood return, and it can become toxic quickly. If client comes in and you palpate this area and it's very tender to the touch, and when you dorsiflex and stretch, it's tender no matter what you do. It's not muscle oriented. They may need, just a cautionary note, they may need to go in and see their doctor because anterior compartment syndrome can have some life-threatening circumstances to it, just because of the toxicity of the blood in that area when it does release, and you can get some necrosis with the musculature in that anterior compartment. You could find anterior compartment syndrome in contraindication books. It's just something to be aware of. Now, I'm just going to start with compression into the tibialis anterior. How are we pain-wise?
A 3.
A 3. Okay, good. So I'm just going to get in there with my pisiform. Relaxed hand. Tell me when I get to a 6. Okay, that's a substantial amount of pressure. And I'm just going to keep it in there. Tell me when it starts to back off. Typically within 30 seconds, it starts to back off with that static pressure. Backing off at all? Starting to back off. Sometimes it starts to back off, I'll get in there and do a little of that compression towards attachment. Now I'm just going to work my way down compression in the tibialis anterior to help open that muscle up. And again, if you do that range of motion, I like to do passive range of motion. That way we don't get engagement of the muscle fibers. Okay. Okay, let me know when I get to a 7.
7.
Okay. And I'm just going to sustain that pressure. Now, one of the reasons I'm just using direct compression instead of using more compression towards insertion is because of that bruise. I don't want to put a lot of pressure and glide over that bruise. There could be vascular damage in that region, and I don't want to cause it any more damage. Usually when bruises start to lighten up, get a nice light yellow, light green, that's when you can start working over the area. How you doing? Okay.
It's starting to loosen up.
Starting to loosen up. Good. And I'll just use my thumbs to really work in that area. Superficial, that bruise, I'm going to compress in with my thumbs and compress towards the superior portion of that muscle. Where are we on the pain scale?
3.
A 3, good. Towards the tibia side, I'm not feeling as much tension. And so there probably isn't as much pain, but near the fibular region of this, my right thumb, I'm feeling it to be a little more tighter. I'm going to compress a little more on that side, and I think that's where the pain is going to increase just a little bit. And let me know when we get to a 6.
Yes.
Okay, right there. And I'm still compressing not into the belly, but towards the superior insertion. Now, one thing, I'm starting to feel my thumbs get a little tired, so I'm going to switch. Take that pisiform, get back into that area, establish again. Really, I want to get into a 5. Let me know when I get there.
Okay.
Okay, 5, and I'm compressing superiorly. As that releases, my hand will be gliding superiorly. I could put my olecranon process in there and do the same thing. Is the discomfort diminishing?
Yes.
Okay, it's diminishing, and I'm feeling it release, and I'm following that release. Again, if I wanted to, I could be doing some range of motion with that foot. Okay, now I've worked tibialis anterior. Sometimes you can work extensor digitorum longus and the peroneals from this side, but I like to wait and do that when my client is prone, along with the IT band. I could get in here, work the IT band if I wanted to, but I like to do it. It's a little easier to get positioning for the IT band and parts of vastus lateralis where my client is prone. So I'm going to do the rest of the quads while she is supine. To start with the quads, I like to begin with the knee, because as the quads contract, they extend the knee, and there is a lot of force put around the knee. The knee is a very complex joint, and with that patella, that sesamoid bone, and articulation with the femur and the tibia, you have a lot of potentials for problems, plus ACL, PCL, MCL, LCL. Just a very complex structure here. So what I'm going to do is start at the tibial tuberosity and just do a little compression and friction. And I want to really loosen up that patellar ligament and move my way around the patella into the patellar tendon. I like to do this with the knee extended. I hit a tender spot. Where was that?
Behind the knee.
Behind the knee. Okay. Was it tickle or tender?
Tender.
Okay. It's always important to distinguish between ticklish and tenderness. Sometimes people will jump if you tickle them, and if it's ticklish, it's okay. You just need to establish a different hold. If it's tender, you went in too deep, or it could be a sign of distortion. Now, as I friction this patella, or patellar tendon, and ligament. I'm really feeling for the condyles, the tibial condyles and the femoral condyles, and just working with those structures. Quite often I will do that compressed insertion where I'm compressing here around the tibial condyle and I'm compressing up into the quadriceps, and as the tissue releases around there, I just follow that release. And quite often this can release a lot of the adhesions with the patella. You can do it like this, how I have my hands. Just so you know what my fingers are doing, my index fingers have just gone around the lateral inferior edges and medial inferior edges of the patella. And I'm feeling a little bit of hypertonic structure there too. I've slowed down my progress and I'm waiting for those to release. Any pain scale here?
No.
Okay. As I was moving through there, did you feel anything on the outside or inside?
No.
No, okay, good. Now, be sure when you communicate with your client, yay, it's nice to know lateral, medial, superior, inferior, but 9 times out of 10 your client doesn't know what you're talking about. So it's okay to say inside, outside, above, below. As you can see, my hands are moving around that patella. I'm feeling a lot of freedom of movement as that tissue releases up into the patellar tendon, because as we know, tendon joins muscle to bone, ligament joins bone to bone. Of course, since it's bone to bone, we have the patellar ligament. Since it's muscle to bone, we have the patellar tendon. A lot of it is feels like the same material. I didn't do it before I started, but before I start, I do like to get an assessment of range of motion with just the patella. Now, some people have easily dislocatable patellas, and it would be good to establish that too. 9 times out of 10, if you have somebody that has very fragile patella that dislocate easily, as soon as you touch there, they're letting you know, oh, be careful, that hurts, I dislocate easily. And it's not that I'm going to be forcing it out of alignment, but if somebody is really sensitive about that, they're going to lock up and not allow me to get in there. So it's part of that trust issue. There are some people that have easily dislocating patellas that I just won't work on their patella just because of some of the issues they have. Now, I just felt part of the vastus lateralis associated tendon release kind of comes around that patella. And I'm going to gently friction. Here's the superior border of the patella. I'm going to gently friction just above that into the patellar tendon, moving superiorly. When I back off, there's no pressure. As I go in, I put in maybe a ½ pound of pressure. I can do that with my thumbs. I can also do that with the heel of my hand. As you can see, just the base of my thumb really provides a nice space for that to take place. And really like to get this warmed up, loosened up. Attachment, I've said before, warm up the attachments, the belly of the muscle will release a lot easier. So having said that, just flex the knee and the hips slightly. I'll come in to the attachments on the femur of the vastus lateralis and vastus medialis, and I'm just going to, you can compress in carefully. There we go. Got your attention. What are we?
2.
A 2. When it initially happened, what did it go up to?
A 4.
A 4. Okay, so it was kind of surprising, though, right?
Mm-hmm.
All right. Now, even though this position with me may look a little awkward, I am balanced on my knee that's on the table, and my leg behind me is kind of counterbalancing my back. Plus, even with my hand here, I'm supported my torso with my hand and my elbow, but I'm supported enough with my knee and my left hand that if this muscle were to twitch or flip, I could back off immediately without falling. Whenever you do any type of leverage maneuvers, make sure that you are properly balanced over your client so that you don't fall into them if they do twitch. Now there's vastus medialis. Now the vastus lateralis, I'll just get in there with the heel of my hand and just compressing. Here's the ASIS. I'm gently, greater trochanter's back here, I'm gently compressing towards the ASIS, TFL, greater trochanter. And that was a lot more tender, wasn't it?
Yes.
Okay. I'm going to compress in again. Tell me when I get to a 7. Okay, didn't quite get there. What did we get to?
A 5.
A 5, okay. This is really always important information to have. One of the main reasons from this position I can't compress in very well, but I'm not trying to compress in. I'm compressing in that attachment mode, kind of going over where that vastus lateralis will attach to the femur. And right here with the vastus lateralis and the tensor fascia, I'm feeling a lot of tension. Because this is tensing up here, I want to go ahead and get into that rectus femoris, which attaches on the inferior because I can feel that rectus femoris muscle kind of protecting. I want to go from my vastus lateralis attachment into the rectus femoris attachment, which is, it crosses the hip joint. It's the anterior inferior iliac spine. And alleviate some of that tension. Where are we?
A 1.
A 1, great, okay. Now, I'm just following. I'm moving down this way. The attachment's right here. I'm moving inferiorly. This is where we were having a lot of the tension issue between vastus lateralis, TFL, and rectus femoris. So I want to kind of glide my hand around until I feel where that tension was, and I feel hypertonic. Is that
Yes.
a little more sensitive? Okay. So that is once again more of the kind of a superior portion of vastus lateralis. Since I'm getting more detailed, I'm using my thumb, compressing in there. As I'm illustrating, it's not always one particular spot. You have to work around, you have to isolate, find, hunt, and figure out those areas of pain and work in there and desensitize it, get the tissue to let go, get the tissue to release. And I'm working slowly. Now what I'm going to add to this is some of that joint compression. I'm going to compress her femur into the acetabulum as I compress the muscle to the insertion, and the dual quality should help assist that release. As a matter of fact, did it just decrease?
Yes.
Okay. She had a slight change when I compressed in there. Her hip actually elevated, and we had a decrease in pressure when I started pushing that tibia. Now as I'm working into the head of the vastus lateralis, as I was putting pressure into the insertion, I came down and also put pressure into the femur, into the acetabulum. And as I did that, the head of vastus lateralis released. There's actually a very visible movement. And how tender are you through here?
I'm not tender.
Okay, not tender. So we had a major release, and because of the insertions, now we can go in and work the belly of the muscle. So it's a similar type of, a lot of people will call it stripping motion. I'm just going to compress here. And I've got my thumb just lateral to rectus femoris and vastus lateralis, and I have the heel of my hand leading it. And I got a little defense response in there, so I'm going to back off. And tell me when I hit a 6.
Oh, 6.
Okay, there's a 6. And I'm just going to sustain that pressure. And as that point starts to move, I'm just going to follow it. I could do this with my elbow. I could do this with my forearm. I could do it with the heel of my hand, the pisiform, or I could do it as I'm doing it now, thumb of one hand and leading the edge with the blade of my other. And has it decreased at all?
It is the same and now slowly decreasing.
Okay, it's the same, slowly decreasing. And as she was saying that, I started to feel a softening of the tissue. And I'm just going to follow this. Now this is a long muscle. This can take a long time. If I want to speed up the situation, I'll keep my thumb there on the inferior points. I can come to the superior points, compress in and push towards my thumb. Now we're working two ends towards the center. As my left hand glides up and I get closer to the groin, I'm going to move my fingers, because sometimes fingers medially can be a little disconcerting to some people. Is the pain diminishing a lot?
It is a 2.
A 2, okay. So we've had a good movement in this region. And I'm going to do the same thing into rectus femoris. If you ever have trouble finding the rectus femoris muscle, all you need to do is have them flex their knee. Go ahead and just try to pick your knee up. Go ahead and pick it up that way. Yep, there we go. There's the, okay, relax. There's the tendon right there. And now I can focus in there and work with it. Now I'm feeling the hypertonic tissue. Actually, I'm going to position more with the knuckle of my thumb. When I change the knuckle of my thumb, does that make it any more tender?
No.
Okay, good. And as you can see, my left thumb is gliding up. The only reason, again, it's gliding up is it's following the release on that musculature. Okay. Now, we still have some tenderness as I move through there. I'm going to do the same thing to vastus medialis. Okay. Now, as I trace up here, we have a spot where, okay, and you could even see it if she jumps. We're good, 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 good. When I hit here, there's a sensitive point. There it is. And that keeps going till about right here. So I keep reassessing until I iron out all of these spots and get everything till it's very smooth. Now you're limited on time constraints. There are a lot of different things you can do, but it's the same process over and over again. You can keep compressing, backing off as I'm jumping, sorry about that. You can keep compressing, backing off, compressing, backing off. Now, Brett hasn't had a lot of body work, especially recently, so she does mountain bike a lot. Pardon me, she does ride a bike a lot. She races, right? You road race?
Yes.
And so it's natural that she's going to have a lot of tender spots. This is what I've been talking about before, is, you know what, we may not be able to go as deep initially, but through repeated work, we'll be able to iron out a lot of these sensitive areas. And it's good to kind of see some hypertonic regions and see them release, and just know that repeated work is going to really help diminish those areas. I'm going to go ahead and move into the adductor region, and again, the same process, the same process. Now, I just will cross the leg like this. I've got this whole region that I can work in. What I like to do is get into the pes serine and work across the pes serine tendon, basically the medial condyle of the tibia, and work that insertion point. It's where sartorius attaches, it's where the gracilis muscle attaches, and it's where semitendinosus attaches. And just crossing this medial knee joint, that will help loosen things up. Then several things you can do. I can take my upper arm and I can trace down this way to work out some of those issues. I'm in a really good position mechanically to make that happen. I can get in here with my forearm and glide down this way. I can also get in and glide this way with the forearm, or get in with my hand. All of these types of strategies will work and give you a chance to switch off. I could even switch knees, get my position with my opposite arm, and really focus in there and work these muscles till I strip things out. The process is the same. Work in, establish the muscle. We have a lot of different adductor muscles. We have adductor magnus, adductor longus. Getting up more towards the groin, we have adductor brevis, pectineus. And you can individually work out all of these muscles. Plus, you could also trace. We have the sartorius right along here, and I could actually trace the sartorius with my fingers. That's typically the way I like to do it. And I could work it all the way up. But these deep tissue techniques work really well for all of these muscles, and it's a great way to get in and open up the lower and upper leg as far as the extremities go. Are you tender through here with the pressure?
A little bit.
A little bit, okay. If you do use your forearms or your elbows, be aware that this is a very sensitive area, especially the closer you get to the groin. And this is where I'll also throw in, take a nice deep breath, and just let it go. And as she lets go, I'm just trying to feel for any further release. There we go. We get a little bit of a release there. If it's being really slow at releasing, get in there, do some more compression. And when you're done with everything, go ahead and flush. Okay, now I'm going to show you how to work on the posterior legs. Once again, warm up the tissue. And as you do this, feel for sensitivity. As you do this, feel for the areas where there may be an issue of pain. I'm checking out her gastrocnemius, her soleus muscles, checking out the IT band, the hamstrings, as I just glide up there. Some of that palmar friction. All I'm doing is where sometimes you use the blade of your hand and you just wave back and forth, keeping contact with the blade, doing the same thing with the thenar eminence. Just waving my hands back and forth. And this is really good because I can get a nice contact with the gastrocnemius. Maybe a little extra here from the joint. If you notice, I'm not frictioning right in the popliteal fossa, but I'm more medial and lateral to the joint. And now, depending on the surface areas that you use to compress, you can use palmar compression, you could use fists, you could use forearms, dual forearm, that way you can get the medial and lateral hamstring muscles, and you can see I went just a little too deeply there. You could also put a knee in. If you're using your knee, you want to be very careful. Make sure you're stabilized as you come over, because you need to be able to control the compression you use. I like to balance my tibia on the edge of the table so that I have a little control there with my weight, and gently roll in. I've even been known to use a foot. It's a little extreme. Not everybody has this ability, flexibility, but you can kind of use this. Again, I believe in using all the body parts you have available to help you do massage work. If I've really been working hard, my hands, my arms, this is a nice way to rest and do some good compression to get in there. If you noticed, I did fold the towel back down just to put my foot on there, unless I cleansed my feet and got ready to do something like ashiatsu. But just another option. Okay. I'm going to start in with the lower leg. Before I even do that, let me just show you one more option with the foot. I've said before I like to bolster with my leg. Bolstering with my leg, you can see how this has a nice lie. The foot can be nice and relaxed over my leg. This also gives me a really good opportunity where I could, in a very relaxed stance, strip out the bottom, those plantar flexors of the foot, work into the arch, and just open up the foot a bit. So there's an option for you there. From this position, I can get ready to work the gastrocnemius and the soleus. In order to do that, I'll put a little tension here. I like to grasp the calcaneus and just dorsiflex using my forearm. I'm not doing a heavy grasping, just kind of leaning in there a bit. By putting a bit of tension on the Achilles tendon, I can get in there and gently work that area, work that attachment. If it's a healthy Achilles tendon, if the person's in good shape, hasn't had any problems with it, you're probably really good to be able to get in there and work it. I'm very careful with the Achilles tendon. This is the strongest tendon in the body, but it also, if you weaken it, if you get micro tears in there, you could run into some problems. So I do want to tell you to use some caution and don't be over vigorous with the Achilles tendon. After I warm that up, and you could spend more time than I have on it, just warming that up. Getting the attachments of the Achilles tendon right along the calcaneus. I'm going to move up into the gastrocnemius. And right through here we're okay. As I get up into the heads of the gastroc, I'm starting to feel some of that tension. So I'll do some compression. I'll also do compression into the insertion. So I'm compressing and gliding up towards the attachment on the femoral condyle. You can use your forearm. You can use your elbow. Obviously, the reaction from there, I'm very isolated and I need to be very careful with how I move. And also watch your posture. My knee is bending as I come in, so I'm not bending over with my back. I can adjust, use my other elbow. Okay, a little too much pressure. How's that pressure, Perrette?
That's good.
What are we? 1 to 10?
1.
That's a 1, okay. It's going to come up really quickly, I feel. Tell me when I get to a 6.
Okay.
Okay. Now if you notice, while I was moving up to a 6, she still had a little bit of defense response. I kind of let her move and adjust with that. And I just maintained my pressure until she said 6. Right where the heads cross that knee joint. And I'm keeping my pressure lateral. And then once I've spent 30 seconds to a minute warming up this region, I can go ahead and work into the gastroc heads. Now as you work the gastroc heads, you can start down here and isolate out like the lateral head. And I could start here, compress in, and keep my pressure going this way. You can spend a lot of time in the gastrocnemius just because it is a very strong muscle. It's also a very tender muscle. This is one in the body that I know, for me, receiving treatment, and as far as giving treatment, you can spend several sessions really taking your time to strip this out and get in there. This can be a very, very tender muscle. And even as I palpate that head, as I roll, I feel just a big ridge. Part of that ridge is the soleus, and the other part is the gastrocnemius. And whenever you feel a tight ridge like that, be aware that you apply pressure, it's going to be tender, and you really need to work slowly. I could spend a good half an hour in this region alone, especially if this is what we were focusing, a good half an hour to sometimes even an hour, just opening the whole lower leg. So as far as the time frame goes, you just want to keep moving slowly and opening everything up. But using the same technique, after I've warmed up the attachments, I can either compress down or I compress superiorly. And as that tissue releases, I'm just going to follow it, and I'm going to maintain within the pain tolerance levels. For the sake of time, we're not going to show the entire process. Just know that it is the same technique. It's just taking patience and listening and working with the body. Forearm, elbow. As you work in there, same thing for this side. Here's the medial head of the gastroc. You can also split down that gastroc head and get into the soleus. Using your thumbs, using the olecranon. By the way, you don't have to be from this position. You can work in this position too. I'm showing a lot of different positions because I think it is important to be able to move around, to have a state of flexion of the knee, to have a state of extension, put the muscle in different positions. If you're warming up the heads of the gastroc, sometimes you can get a little range of motion in there, as we've done before. Get into the soleus muscle. Dorsiflex, plantar flex, dorsiflex, plantar flex. I like to do passive range of motion with my clients so they're not engaging muscle fibers. Some people like to engage and have active resistive or active movement as they work the musculature. I do want you to know you have a choice in the different things that you do when working these regions. I know some people that will even get in and place the foot over their shoulder and work in from this position, just as a matter of stabilization using their fingers. So there are a lot of options working the gastrocnemius and the soleus. I'm now going to go into the peroneals. As you're working the peroneals and the extensor digitorum longus, sometimes you can, I'll just get my knee up here. Now, bony, sensitive, be careful with your pressure, but this allows me to just kind of stabilize the foot there and actually use both hands or do that compression on either end of the peroneals, either tertius, brevis, longus, or extensor digitorum longus, and get those muscles to come together. But this is just another option here. I'll also do something like this when I'm working in the upper thigh. But just different options and different abilities to get in there and work. If you notice, even from this position here, with my foot up on the table, instead of having to bend over the table like this, I now am more positioned over the table where I can move my center of gravity in. Now, I know some people have issues with the therapist standing on the table or getting on the table or moving on the table. In some states, there are even laws against it. But some states, as long as you keep one foot on the floor, you're fine. One foot is on the floor. This is just a leverage advantage for the massage therapist. And I can just flush that region. Now I'm going to also move up into the IT band vastus lateralis TFL. Positioning is a big part of this. I like to abduct the leg just a bit and internally rotate the femur with the knee flexed. And this gives me a great surface to work on here. I can get that IT band up to where the gluteal attachment moves in. I can, again, use a lot of different positions. I can glide with my palm. And this is where your Tai Chi comes in handy. Glide with the palm. I can glide with my forearm. I can glide and strip and be very, very point accurate with my olecranon. I can also, from this position, again, with my knee, stabilize the foot. I'm not putting a lot of pressure in there. I'm just stabilizing the foot so it stays there. Now I have both hands, and I can do some really nice compression in this area. And remember, vastus lateralis, which lies under the IT band, it doesn't stop here. It comes most of the way back till biceps femoris. And it can be, especially with runners, bikers, skaters, very, very, very tight, tender muscle that can use a lot of work. And from this position here, I can spend a lot of time just compressing in. If you do get in this position here, I would suggest dropping your table down a bit. If you have your table up really high, you have no way to get leverage or use leverage in there. With the table down a little bit lower, you can see how I'm just in a really comfortable position and I'm right over my work area. Also, if she happens to kick with my knee being here stabilizing, I'm not going to have any groin issues, groin problems, which sometimes therapists don't think about when they start moving around on the table. Their client may jump. So, same types of ideas. I can get in here and really work the head of the fibula and the lateral tibial condyle and work those insertions. I can then get up into the TFL. Spend some time in the TFL muscle itself. Work that iliac crest just posterior to the ASIS. Get some of the frictioning in there, those attachment points. And you can also direct some of your pressure in. Just wait for that release. Another option I'd like to throw in. When you have your ulna down and you're using it as a working surface, a lot of people will get in there and grasp their hand like this and work really hard. The more relaxed you can stay, the easier you can get in there, the less damage you'll do to your body. And also, instead of just keeping that ulna fixed, you can actually, by supinating and pronating your hand, you can use that ulna as a rolling pin. Another surface area you can work with. If that's too stimulating, roll onto the flexor side. Way too stimulating. Sorry. Roll onto the flexor side. And you can actually use this as a broad holding point using your forearm as a tool. I'm using my left hand to just compress the softer flexor side that's relaxed into the tissue. This would substitute as a palm. A lot of people will work like this with the palms of their hand and really overextend their wrists. And this gives you a point to kind of relax in there and give a good surface area of work with. Another option. Now, after we've really worked up that IT band, and especially through the IT band and gotten into the vastus lateralis, we can flush that region. Just use the flow. Here's some positioning for biceps femoris. Get into the attachments. Get into the short head attachment on the femur. Do your compression. Palmar. And when I do this, my hand is very, very relaxed. If this causes you pain, don't do it. If you want to get a good compression and you want to come down in this position, go into your fist. Be sensitive to the regions here as you're using your fist. Again, relax your hand. Don't make a fist like this, nice and relaxed. It has a lot more give, it's a lot more comforting to the client. Sometimes people are just reacting to the fact that you have this pointy area and you're jabbing repeatedly into them, and it's very painful. It's an assault. And if you can soften that blow, they'll relax more and you can spend a little more time before you start to get detail oriented. From this position, I can also work into the medial head of the biceps femoris. Now, since we're abducted, I'll just use my leg there again as a bolster. and I want to be able to get up to the ischial tuberosity. So we've worked the attachment. Now we'll get into the ischium, and we can use our thumbs I can also warm up that ischial tuberosity with my elbow. I can support here, come in with my opposite elbow. And now I can start working up that medial head of the biceps femoris. Same idea, same routine. A lot of times, just depending on how you internally and externally rotate the femur, you can get really good positioning on that muscle. I highly encourage you to feel what's happening. Rotate that femur a little bit. Feel how things change and adjust when you work. This is again one of those dances. If you're getting your Tai Chi working for you, this can be a dance where you work in, work out, work in, work out. And just the interplay of this type of a dance allows you to be very effective and very smooth and flowing with your body work. It takes practice and habit, but your body will love you later just because you won't be killing yourself as you work on someone. Now, after we get done stripping out, repolarizing the medial head of biceps femoris, what I like to do, I could work semimembranosus, semitendinosus from this position, just internally rotate even more and work this way, or go around the table, adduct the hip a little bit, work this way. But the way I like to do it, the way that's comfortable for me, is I'm just slightly abducted. I actually sit on the table, and from this position you can see I'm right aligned with semimembranosus, semitendinosus. I can get into that pes serine tendon through here on that medial tibial condyle. This is a really good position to, easy as I go, get into popliteus. Just pushing, getting behind that head of the gastroc. Working in there. And from this position, I can also rock back and forth. There we go. Softened up popliteus. Working the attachments of semimembranosus, semitendinosus. And from this position, just taking my elbow into that ischial tuberosity and rolling my ulna. Now from this position, as I work in that ischial tuberosity, one thing you might be able to notice is I'm not just using trunk lateral flexion to move me up. My left foot is down here on the floor and is actually moving me when I am done with the pressure phase. It actually assists to pick me back up. My pressure stroke into the leg is coming from my right leg, and I'm actually pushing on the floor, working my way in there. I'm actually using my left hip as a fulcrum to rotate back and forth on. This again allows me to stay relaxed, focus on the tissue, stay balanced so I have a lot of control over my pressure. So if I need to sustain something for a long period of time, I just lean in here. I'm using the larger muscles of my body to keep me in position. Plus, I can take a break. I sometimes joke and call myself a professional leaner. What's also really nice from this position, after I've done a lot of the compression and the compression towards insertion of the musculature, if you have muscles that are lying together, which occur all over the body, it's really significant with semimembranosus, semitendinosus. I can feel the separation of the two tendons right here. And I can take my thumb and actually gently separate the two, which will help even more the muscles kind of glide past each other. They're next to each other, doesn't mean they should adhere to each other. Now, doing that with my thumb, if your thumb's had it for the day, hey, take the olecranon process, take your elbow, a little more concentrated, gentle pressure, you can do the same thing. I even joke sometimes from this position as I can get my crunches in too. After I'm done with semimembranosus, semitendinosus, this could also be an option at getting attachments of the adductor group. I can easily hit gracilis and adductor magnus from this position, just working in. If the leg starts to push more and more, abduct more and more and more, I just need to throw my knee in there to stabilize, and I can really work into those adductors from a different position. This can be less invasive for people. Sometimes when you're lying supine, your hip is abducted and somebody's in between your legs. Some people are a little uncomfortable with that. From this position, they're protected, they're prone, the yin area is protected by the table, and I can get into the adductor group and they'll have less of a problem with it. So here's just another option for you. Sitting on the table here gives me really good position of getting in and working those adductors. I could even, and I wouldn't necessarily unless I knew the client really well, I could even get into the ramus of the pubis on the attachment of the adductors from this position. After we're done working on the legs, we can just flush everything. And that's okay too. That happens quite a bit. Sometimes I'll get rid of a bolster after I've been working because the client becomes so relaxed they really don't need it. The joints even out and they don't get the cramping. Sometimes in the feet that a bolster helps offset. Brett, your legs feel a lot less sensitive.
Yes, they feel very relaxed.
Good. All right, I'll flush and cover up and move to the other leg. Now, one thing, as I'm working tibialis anterior, it is part of the anterior compartment, and you have to be really careful with the anterior compartment. I mentioned we have a bruise on here. If there's damage to the anterior compartment of the lower leg, one of the dangers that you have is if you get any swelling in the anterior compartment, It can actually inhibit blood flow to the lower leg, and even more so inhibit the venous blood return, and it can become toxic quickly. If client comes in and you palpate this area and it's very tender to the touch, and when you dorsiflex and stretch, it's tender no matter what you do. It's not muscle oriented. They may need, just a cautionary note, they may need to go in and see their doctor because anterior compartment syndrome can have some life-threatening circumstances to it, just because of the toxicity of the blood in that area when it does release, and you can get some necrosis with the musculature in that anterior compartment. You could find anterior compartment syndrome in contraindication books. It's just something to be aware of. Now, I'm just going to start with compression into the tibialis anterior. How are we pain-wise?
A 3.
A 3. Okay, good. So I'm just going to get in there with my pisiform. Relaxed hand. Tell me when I get to a 6. Okay, that's a substantial amount of pressure. And I'm just going to keep it in there. Tell me when it starts to back off. Typically within 30 seconds, it starts to back off with that static pressure. Backing off at all? Starting to back off. Sometimes as it starts to back off, I'll get in there and do a little of that compression towards attachment. Now I'm just going to work my way down compression in the tibialis anterior to help open that muscle up. And again, if you do that range of motion, I like to do passive range of motion. That way we don't get engagement of the muscle fibers. Okay. Okay, let me know when I get to a 7.
7.
Okay. And I'm just going to sustain that pressure. Now, one of the reasons I'm just using direct compression instead of using more compression towards insertion is because of that bruise. I don't want to put a lot of pressure and glide over that bruise. There could be vascular damage in that region, and I don't want to cause it any more damage.